कितनी ऑब्जर्वेटरीज आते हैं
सर? 200-300 प्लस आ जाते हैं।
अच्छा, तो ठीक है, ये भी काफी है। और वैसे लाइव कितने चल रहे होते हैं फेसबुक पे?
सर ये लाइव अब आज हम ना दूसरी दफा चलाएंगे इसको लाइव, इनके आपका सेक्शन।
अच्छा,
पहले मतलब हमने चलाया था लेकिन वो मिड में चलाया था, तो आज मतलब मैंने सारा सेटिंग पहले सीखी है सारा कुछ, तो अब इंशाल्लाह ताला लाइव भी चलाया करेंगे।
चले 245 पे मैं फिर स्टार्ट कर दूंगा, और
ठीक सर।
उसमें आप इंट्रोडक्शन करवा देना 245 पे, ठीक है?
ठीक सर।
245 पे आप 5-10 मिनट जो लेने हैं ले लो बेशक। तो
ठीक।
आपने अपनी कोई अगर शेयर करवानी है, कोई स्लाइड शाइड पहले शेयर करनी है तो कर लो, कि ठीक है यहीं से शुरू करें?
तो यहीं से कोई मसला नहीं है।
अच्छा,
ये लेटर बिल्कुल सही है, इसमें कोई मसला नहीं। डॉक्टर अभी कह रहे हैं कि मेरी पूरी साल की मेहनत है, ये जो है वो मुड़ा हुआ है, ऐसे मिट्टी लगी हुई है, मुझे नया लाना
तो नया कोई ये भी इस पे हो जाए आपका बना देना। बात सुनो, तो आप इंट्रोडक्शन कर दो, फिर से स्टार्ट कर लेते हैं।
Assalamu alaikum everyone. I'm Muhammad Rihan from Association of International Dentistry. Hope so you will be fine. Here we have another webinar about examination of articular disorders. Actually, been we have been discussing from anatomy of TMJ. Then we have discussed disease of TMJ. Now it is turn of examination. So I am handing over to Dr. Arshad. Thank you so much.
बिस्मिल्लाहिर्रहमानिर्रहीम. हेलो एवरीवन. मेरी आवाज ठीक आ रही है? कुछ कम तो नहीं है?
No, sir, it is all right.
Okay, good. Actually, what we've been studying is the temporomandibular joint. And temporomandibular joint is what you see is a sea of knowledge with reference to the other joints as well. It's a very small joint, but it has so wonderful presentation that it is the only joint which used to move maximum in the day. No other joint is so mobile as the TMJ is. It is the only joint which is used to develop the phonetics as well. It is the joint which used to masticate as well. It is the joint which gives you the aesthetic of the face as well. So these all character of this temporomandibular joint make it so important that this has been proved that there must be a TMJ studies, or we say separate subject, or you say separate department, or a separate entity in the medical field. So for that purpose, temporomandibular joint has a very identical presentation in a whole of the dentistry as well. It's a small joint. It is a synovial joint. As it is a dihedral joint. It is a wonderful joint with reference to control of the movement bilaterally. The only joint in the whole body which has the bone having two joints, but they are moving with one equilibrium. And if this equilibrium is slightly changed, the shape of the face is changed, the phonetics are changed, the beauty of the face is gone, as well as the function is disturbed. So for keeping in mind, Association of International Dentistry has organized this whole seminars into different seasons. So for first season that we have started was just ABC of temporomandibular joint. We started right from the development, covering all the parameters of development of temporomandibular joint. Then we come to the anatomy. In anatomy, we covered first the histopathology, histology in detail. And we cover right the joint fossa, disc, condyle, and the ligaments. All the micro details present in all these 3-4 structures has been evaluated and has been discussed in 3 lectures. Then we've gone to the diseases of the temporomandibular joint. This was the season 2, and this season 2 has remarkably given the detail of that. Its third season, with reference to the detail of the temporomandibular diseases, with reference to musculature, with reference to TMJ osteology, with reference to the developmental diseases. These all been covered in the season. So today, what we are going to do, that what the background we have seen during our previous seasons, and that is the basically to understand completely the temporomandibular joint, its osteology, its histology, its development, its muscular attachment, its function, its equilibrium, and it's basically it's all diseases which are related to temporomandibular joint, with reference to pain, with reference to tumor, with reference to muscle. That has been covered in all previous our seasons. From today, we are going to cover the season, and this season will cover absolutely the examination and diagnosis of the articular disc disorders as well as the temporomandibular joint disorder. And in this diagnostic period, we will discuss the history, we will discuss the examination, we will discuss the investigation, what the investigation we required for temporomandibular joint. For that purpose, what we have planned, that we will just go for the simple means, and those simple means are the charting of the examination or diagnosis system. And for that purpose, the first thing we have designed is that the charting. So this is what you say is the charting. These are, you see, there are two charts. One is the manual function analysis. On this side, this is history. And on this side, this is inspection and examination. If I take this examination chart in front of you, and we will see the analysis of the, what are the manual function analysis we are going to discuss. The first thing is you will see the record of date, then we will move to the history. The symptoms which the patient used to say are generally pain, limitation of the movement. Movement you have to check, right, left, anteriorly, posteriorly, or opening and closing. Then you are going to check the clicking, and that clicking history patient will be report you that it is irregular, it is just by I go for yawn or I open the mouth widely, and then you are going to have the history of occlusion. Now that is very important. Now occlusion is a functional occlusion. Generally, you have to look for, which we have during our etiology, we have discussed in detail the parameter of occlusion. What are the different occlusion exert pressure on the temporomandibular joint, and that different crossbite, posterior crossbite, anterior crossbite, traumatic bite, and lack of interdigitation, and same we are in the deep interdigitation, like what you say in bruxism. So these symptoms are the first which you are going to analyze. Order of the symptoms you have to check. Number one is from the left side or the right side. It is the clicking on the right side, on the left side. Then you are going to see the pain on the right side of the left side. Now, this all things you have to calculate that what you are going to see in the TMJ. Next is the patient expectation. Patient for the TMD actually very much anxious. It has multiple problems. These problems are specially related to the psychological parameters, then functional problems, then habitual problems, then problems with reference to occlusion, mastication, diet intake, and fitness of the person in the society. And that is the main problem, that the people do not actually uh, uh, expect that you are going to take the time. They expect that, well, I am coming before you, so I must be relieved in a just simple go. And whatever the what you say treatment you are going to plan, just give me the relief. And that is the expectation which you have to consider. So the main thing we say, that the person who is with the temporomandibular giant pain dysfunction syndrome, he must be pain free in the very initial stages. Then is the tissue specific primary diagnosis. That is, a person have to look for. It is right and left you have to describe. The loading factor, you will decide whether it is present on the left side or the right side. Then you will see the clinical static occlusion, dynamic occlusion, bruxism, and dysfunction. And this from right to left, everything you have to note it. Tissue specific secondary diagnosis. This is also whether present on the right side or the left side. Then the loading factor same, and then the same clinical influences with reference to tissue loading. Now these supplementary diagnoses are also very important. You have to check these are helping parameters, and these are MRI, CT, panoramic, lateral ceph, articular adjustment, instrumentation, occlusion analysis, analysis of etiological factor, joint vibration analysis, osteopathic examination, and these or anything else if there are any supplementary diagnostic measurement has been made. Then is the initial dental therapy. Removal of the occlusal influences, whether it is a casual or symptomatic. This you have to assess, and then you have to propose the supplement. For the occlusal vectors, alteration in the vertical dimension, anterior and canine guidance, especially from the crossbite, and protection of the enamel, especially when we are having that traumatic bite and bruxism more than that. Vertical positioning, condyle stabilization, and unspecified muscle relaxation. And for that purpose, you have to see the occlusal influences. Then is the condyle position. Now, condyle position is based on many things. One is the neuromuscular things, and neuromuscular things are that whether they are centrally physician determining position, that is the physiological parameters, and that physiological parameters basically are very important to be understood, and these are the determining position with a physician used to do. Then is the occlusal suppling design, upper, lower, disc repositioning, flat, when the impression is taken, which type of impression is taken, when you will see the vertical disclusion, dorsal protection, flat impression, no contact. These are with every reference to every tooth you have to see. And lastly, you have to look for the local uh, restriction like traction, translation, static and dynamic, and muscle stretching, mobilization of the suprahyoid structure, alteration of the functional pattern, and same thing for the systemic influence like manual therapy, osteopathy, homeopathy, acupuncture, physiotherapy, any other thing which the patient is using. And definite dental therapy, you will see after all the analysis, which is the superior one, occlusal adjustment, prosthodontics, orthodontics, orthognathic surgery if required, and lavage. And that is now the second thing which is important is the examination and inspection. Now this is all we will going to study in next coming slides, and then the examination of the bimalar and traction and translucation parameters. Then we are going to see the muscles, what about the elevators, what about the depression muscles. Then we will see the lateral pterygoid left, lateral pterygoid right position, and same for the length of the suprahyoid structure. And then we are going to see the palpation. Now that is the thing which we are going to see next coming slides. And then we are going to check the clicking sound. Ladies and gentlemen, after having this whole analysis function in your mind, then you are going to have the proper examination of the temporomandibular joint. Ladies and gentlemen, this manual function analysis is a form in front of you. You can make the copy of it as well. And I mean to say that every person who is here must be capable of analyzing the uh, whole of these two charts. Now, the first thing which in the chart is written, that is the opening and closing movement analysis. Ladies and gentlemen, the normal opening and closing of the mouth is 35 to 45 mm. This is a normal opening. In this opening, the joint remains after translucation goes back to the joint, and there is no any sound, there is no any deviation, and there is absolutely no problem with the patient pain dysfunction. Next is the limited opening, and that limitation of the normal opening is generally less than 35 mm. You see the submucous fibrosis, you see the temporomandibular joint problem, where these opening and closing become very, very difficult. And these are called as the limited mouth opening. And what about the wide mouth opening? You see the absolutely so wide, that is more than 50. And that is the exaggeration of the opening of the mouth. And this exaggeration actually results in the torque on every parameters. The torque on the muscle mastication, torque on the infrahyoid muscle, torque on the joint disc, as well as the capsule and the ligament. These all are the requirement of what you see 35 to 45 mm routine. Less than 35 is called as the less opening, and more than 50 is called as the exaggeration of the mouth. Now, how to measure it? Some people used to measure it by means of just foot, but this is better that the portion of the measuring instrument must go inside the, sorry, it must go inside the mouth, so that incisor opening must be in your mind. And then is the lateral exertion. It should be, you place the thing in the mid of the upper incisor, and you will come to know how much the lateral exertion is there. And that is very important, that you must know that it should not move more than 10 mm from one side to the second side. Now, when opening and closing examination is there are two methods. One method is called pre-tragal method. Just you stand in front of the patient and place your both fingers in front of that tragus, and ask the patient to open the mouth and close the mouth. While in case of intra-articular, you go posteriorly, put your small finger in back of the tragus, ask the patient to open the mouth and look for the posterior movement of the joint and the disc, and that will be a very promising thing. Look at this, that you are going to place front of the tragus and you place both index fingers there, and these both index fingers results into opening and closing of the mouth, and if there is any sound, you will see that there is sound. And second is, you put your small finger on the posterior aspect of the tragus of the mandible, and you see whether there is any sound while you are opening the mouth or not. So that is the opening and closing movement of the temporomandibular joint, how you are going to note it. Now, the things which are pathological in nature are the midline deviation or midline deflection. Either it is called as the midline deviation or it is a midline deflection. That you have to understand very nicely. Mandible returns to the center position on opening, indicative of interference during condylar movement, a prominent sign of anterior disc displacement with reduction. So as you open the mouth, the mandible first shift like this and then again into the center. Open in the center, but during opening it is slightly deviated, but again it shifts to midline. While in case of deflection, a continuous displacement of the mandibular midline along the whole opening movement. This is the center line. The mandible moves, but it is moving on one direction. And this is a common sign of anterior disc displacement, that is called without disc reduction. So when you open the mouth, this comes with us. When it here you produce the click, and then you again closing it, and then it is coming back. When you will close it, it will again come back, and it will do click here, and then it will be closed. So this portion is the portion where click used to occur, but here there is no click, and it is just one side it is going on, and that is that the disc is displaced without reduction. No, disc is not going back. It is like this. You see deviation is opening and it is closing. It opens and it is deflection right here. While in case of deflection, You see, it is just the patient opens the mouth, this is deviation. You see, the deflection is only one side. It just open, close, open, close. It is full deflection. There is no coming to the center. Why? In case of deviation, you see, patient opens the mouth, close it, and there is just, you see, it is like this. Okay. Now, if I give you a very good example of deviation, deflection is easy, but you see this deviation. You see, it opens and it closes. It's a big deviation there. That means there is disc displacement with reduction. Now, the next examination is the masticatory muscle examination. So, muscle of mastication, when you talk of the muscle of mastication, we have covered all the muscle of mastication, and you see, muscle of mastication important is the group which is masseter, temporalis, medial pterygoid, and lateral pterygoid. Muscle of mastication, the first muscle which we are going to see is the masseter. You see, you start from the anterior aspect, checking right from the below to the above and the same posterior limb. And on the other side, you just check the cheek, posterior to cheek, just the posterior to buccinator muscle. You are going to place your two fingers here. You see here again. This is how you examine the masseter muscle. Here you are checking any tender point. You are checking bulk of the right masseter muscle is equal to the left masseter muscle, or the both muscles are in one line, in one orientation. Patient feel any pain by touching any muscle, either it is on the right side or either it is on the left side. That is the check of the masseter muscle. Now, next muscle is the temporalis. Right from the forehead, you move posteriorly and you check the tenderness point. And that is the very important. Just posterior to the lateral orbital area, one hand front, one hand back, and you cover all of the temporal area, and especially this area which is right here. You are going to check the temporalis muscle. Is the size from right side and left side? Is any tender point on the right side or left side? It's opening, and the bulk of the temporalis muscle you are going to check. Now next. Now you are going to check the medial pterygoid. Medial pterygoid muscle is placed on the posterior aspect of the ramus on the medial side, and you place your index finger right there, and then one finger just holding it, and second finger you are pushing it behind the buccinator muscle to the medial side of the ramus, and you check the tenderness point of the medial pterygoid muscle. You go behind, from here to you go behind, and that is the place of the medial pterygoid muscle. Now next is the lateral pterygoid. right posterior to the tuberosity. You place your finger posterior to the tuberosity and check the lateral pterygoid muscle attachment, and you will see the tenderness, pain, and then you are going to check the contralateral and how much the pain patient has. You have to check it very accurately. It is like this: you push it, go behind, and then you touch it. Now we are going to check the neck muscle. These neck muscles are the sternocleidomastoid. You check it by this. Then you are going to check the deep muscle of the neck. Then you check the trapezius muscle. And these muscles must be palpated with reference to pain, tender point, any stiffness, any movement difficulty, and patient comfort. This especially you have to check the sternocleidomastoid, asking the patient to look on the opposite side, and you see the bulk of the sternocleidomastoid. Same you are going to repeat on the opposite side, and you will come to know that how much you are involving these muscle orientation with reference to your diagnosis. Now that is very important, that the sound sometime of the temporomandibular joint is very important, and these sounds you have to go for. Listen, sometimes these are so obvious that just patient open and close the mouth, you are far away from them, then yet you are going to observe. But sometimes there is sound, but it is not so obvious, so you are going to check it by the stethoscope. Now these are the different stages where the temporomandibular joint is going to open and close. Now, reciprocal skill is that when you open, it is also there is sound, and when you close, it is also there is sound. Then is reproducible opening click. When patient opens the mouth, then there is click, but when the patient closes it, there is no one. That is mean reproducible click. Then closing reproducible closing click, that is open the mouth, no click. When there is closing of the mouth, there is close. Sometimes there is fine crepitus, and this fine crepitus is due to the loss of temporomandibular joint structure, and that is due to loss of the disc, and there is constant sounds, rubbing sounds on the surface of the condyle, and these are the 5 fine crepitus. The third is the coarse crepitus. Too much joint structure is lost, and then that is when the patient try to close or open it, there is too much noises due to the rough surface of the condyle as well as the rough surface of the glenoid fossa. Popping is a sound when there is a great damage to the disc, and that disc is used to reduce medially more as compared to anteriorly. So when it moves to a medial, there is a big pop and big sound appears when there is opening of the mouth. That when we were studying that temporomandibular joint sounds, we have discussed all these things in detail. Now, this is the best way. You place the stethoscope right there, and then you get the sound by the stethoscope. Some people, they also place bilaterally, and you check the bilaterally sound, and that auscultation, I think this is the one of the wonderful method for auscultation. People used to say what are the questions in neurosurgery, that where are we are going to have the auscultation. We are going to have the auscultation of the maxillary sinus fluid. We have the auscultation in the any big cyst fluid. And third, the very important, that is the main thing, that is the auscultation of the temporomandibular giant. There are available Doppler. They also give a very good sound record when the patient open or close the mouth. After that, we have seen now the people have started the soft laser response on opening and closing of the mouth, and there is the assessment of the sound. And sometimes ultrasound analysis are also present there. You place the ultrasound when you open and close the mouth, and if there is any problem in the disc, the sound is there, it is going to amplify the sound, and that is going to help you a lot. Then is the Mohan sign. This is a very important thing that every dental surgeon must know. The contralateral pain suggests the articular disease. It is like this, that you place right here and the pain is right here. So it is called as the Mohan sign. Contralateral pain suggests articular disease. You're pressing here, pain is on this side, and that is what you are going to look at that. Now, next is temporomandibular giant investigation. These are the examination, manually, sound, anterior, muscles. These are three things you have to check for the temporomandibular giant investigation. Now we are coming to the different investigation. First is the OPG. It's very important that the limitation of the opening of the mouth, it is not only by the temporomandibular giant disease itself. Sometimes there is a trauma and loss of the coronoid process. These are going to result into temporomandibular giant dysfunction syndrome. Sometimes there is calcification of the styloid process, what is called as the eagle syndrome, and the patient is unable to open the mouth properly. We are stressing temporomandibular giant problem, but it is right here where the stylomandibular ligament has been calcified bilaterally, and there is pain on this area due to calcification of this. So temporomandibular giant radiology is very important, and you have to assess what is the cause of this loss of the temporomandibular giant and why this is a sound produced at this level. So that is very important to understand. After getting the OPG, you will come to know. Now, next is the radiography of transpharyngeal view. It is like this. You place the right in the pharynx level, absolutely parallel, and you will get this image. And that is called as the transpharyngeal view. This is the first view I have shown you. The next view is transorbital view. You place the cone right in front of this and you targeting the temporomandibular giant. It will give you a very good sagittal appearance of the temporomandibular giant. It is placed like this and you just fire, and that is the image coming right here, and that is the transorbital. Closed mouth and open mouth, both technique can be used, and that is the image you are going to get it right from here. When you open the mouth, it is like this. You open the mouth and you take the transorbital image. It will be lightly deflected here, and that is the giant image. It is a very clear image with reference to the sagittal plane, and the result you see it is like this. Coming from the orbit on the counter lateral side and deflection here, and that is the image you are going to get from the, and it is a very good image below to the articular eminence. Now the transcranial image is also important. Just you place above to the ear and direct it at approximately 25 degrees to the second side, and this 25 degree will reflect the open mouth and closed mouth of the transcranial image, and that is a wonderful image also giving the detail of the condyle. And that is the close, when you have taken the close image, and that one you have taken the open image. That is the glenoid fossa that is open, and now the joint is anterior to the glenoid fossa, and now this condyle is back, and these are the two very good images of the transcranial view. And that is the TMJ P4 we are going to use, and that is the wonderful images. You see there are the different images of the different diseases. Here you see the absolute abrasion, there's nipping, there's the loss of the nipping, and there's condyle is just rotating beneath the cranial surface. It is round off, and there is the anterior loss of the joint, and that is the flattening, and that is the normal temporomandibular joint. Now this is a CBCT of the temporomandibular joint. Patient is very stationary during this taking of the temporomandibular joint radiography, and when you see that the patient has taken, it is the 3-dimensional, even you will go deep slice of this area, and you will come to know the depth of the temporomandibular joint, disc as well as the bone. Then we are going to have the real life time MRI. You see, this is a wonderful image of the live patient MRI. Patient opens the mouth, close the mouth. This is the disc. This is anterior fibers of the lateral pterygoid muscle. This is the inferior fibers of the lateral pterygoid muscle. This is the posterior laminae. These are the external acoustic meatus, and that is the part of the brain of the middle cranial fossa, and that is the middle cranial fossa bone. And this joint is moving live with the MRI, and you will come to know that disc problem is not there. Disc is coming right there with the condyle, and it is staying there, and now it is going back with all the laminae intact, with all the fibers of the lateral pterygoid muscle, they are intact. And this is a very good interpretation of the disc position or disc prolapse. Now, when we take the CT of any region, you see, if you take here, and you are going to get the image right from here to the condyle. You are coming forward, you are going to back or forward, all the condyle images, and from anterior surface to posterior surface you are going to get, and that is a wonderful image of the temporomandibular joint. Now this is CAT scan of temporomandibular joint movement in open as well as in functional way, and that is another very functional investigation for temporomandibular joint. Now next is the TMJ orthocentrosis. Superior joint space, you put the needles and you push the liquid from one needle, and it is coming out from the second needle, and from this swab you can see whether it's any blood, whether there is any infection, whether there is any pus formation in this joint, and we will understand that how much this joint has inflammation, and a joint has the problem. So that is the, you again see.
Medical administration, medical administration control इसकी ज़्यादा प्रिंसिपल है डीन के केस में सारा मेरा नाम ठीक ये उनका नाम सब उसका भर बाकी डेट शीट है वो सारा कुछ निकल होगा.
Now we are going to see another investigation, and that is very important, especially for the postgraduate pupil, and that is the temporomandibular joint arthroscopy. And that is in few centers in Pakistan, they are performing the arthroscopy, but this is a very, very important thing. And I think that every maxillofacial surgeon must be aware of this great investigation. And that is, you see that the superior joint space is being probed, and the probe is inserted into superior joint space. It is like this. And same, you will see that you are in the superior joint space. Now you put the camera inside and you are going to check for the camera. You see this is the condyle. That is the condyle. You see, this superior area is the glenoid fossa, and you see the smooth surface of the condyle. There's a few debris of the damage, what you say, disc there, and you see the small fibers of the damaged disc is there, and that is the thing which you have to look for. Well, the butt portion of the disc is damaged, and it is by the arthroscopy. It is like this. You place it and here. Then you check it by placing the fluid inside, and when you confirm it, then you attach the camera with it. Now, ladies and gentlemen, in this whole period, today we have discussed the whole detail of the diagnosis and different investigations, taking of the history of the temporomandibular joint. Now we are going to start in our next season, that is the management of the temporomandibular joint diseases, and that is if you have any question regarding today's discussion, I am here to answer. It is over to the Association of International Dentistry.
Dr. Rashid,
Thank you very much.
Dr. Rashid,
Gigi.
which investigation method is more preferred?
The best investigation method for the undergraduates, for the graduates, for the I'm sorry, you have to go according to the status of the disease, not in the initial stages, that you are going to have the big investigation. The first investigation you are going to take, that is the simple OPG. Then if there is long persistent and there is a disc problem, then MRI is preferred. And these invasive investigation like arthroscopy or scintigraphy. These are the invasive investigation. These should be done at the end. CBCT and MRI are the what you say, the classical temporomandibular joint investigation.
Any question, kindly put in your chat box so that we can forward it. Perfect. I think there is no more question, Dr. Rashid.
Yeah.
Thank you so much for your precious time and this whole season. We have now covered anatomy of TMJ, disease of TMJ, and its examination. In our next session, we will cover management planning of TMJ disorders. And for your certificates, there will be a quiz on our website. You have to attend that quiz, and on that basis, you will be able to get your certificate. Yes, sure, you can ask question.
So if there is no question from here, we are going to close the session. And
One person
inshallah,
likes to ask question.
yeah.
Dr. Iman Afroz, you have asked. If you are not able to ask, kindly put in your chat box. Can you please explain mechanism sign a bit more?
Actually, it is very much related to the. I just go back and I explain again. You see, this is Sumahan sign. You put the tongue blade, or you put the cotton, or you put anything on the side here. In this side, what is going to happen? Now try to understand. Temporomandibular joint move like a seesaw. It is seesaw like this. One side you bring the jaw downward, and second side you press the jaw upward. If you press the teeth on one side, you are bringing the jaw downward, and second side you are lifting the jaw upward. You got my point? The side which you are biting, you are basically pulling the jaw downward, and the side which you are pushing above, and that is non-functioning. So functioning side will come down and non-functioning side will go up. So if there is pain on the non-functioning side, it is this one. That is called as the articular disc disease. That means your counterlateral side is not painful. There's no disease here, but it is this area which is diseased. You got my point. This is called Mohan sign. Yes.
Doctor, there is another question. Do we have to make the patient bite on wooden stick necessarily?
Please pardon again.
Do we have to make patient bite on wooden stick necessarily or any other thing?
Best is the wooden. because wooden is a crushable fibers. So there is no extraordinary pressure on the joints. It is just a simple thing. Some people do place the cotton there. Some people do place fibrous things there. But the ideal one is the cotton, this tongue blade, wooden tongue spatula, which is generally called as.
Why we palpate neck muscle?
Neck muscle are the groups of the, what you say is the inframandibular group, the lateral group, and the posterior group. The inframandibular group are the digastric muscle, stylomandibular muscles, ligament, and the anterior belly of the digastric as well. These muscles are being palpated by asking the patient to pull the chin upward and you examine it like this. Second is right and left portion. Right portion, when you are going to check, you put the head on the left side and then you examine all the right side of the muscle. While you are examining the left one, you ask the patient to pull the neck right side. In the posterior segment, you ask the patient to pull your head front, down, and you place the both finger on the back side, and you place yourself as well on the back side by checking up the trapezius intensity. This is the way how you check the neck muscles.
Do anyone has any question or should I close it? How to differentiate between tension headache and myofascial pain headache?
There's the tension headache is basically not related directly to any muscular spasm or muscular contractures. But the myofascial pain has the multiple origins. These myofascial pains may be origin of the temporomandibular joint. They may be origin of the tender point at the any muscles, and so they are easily differentiated by the tension headache has a definitely signs of the tracking zones. So you see the tracking zone in headache, while in myofascial pain you check the trigger points of the muscular spasm as well as the trismus points.
What is the sequence of muscle palpation in TMPDs?
We say that first you start from the masseter, then go to temporalis, then go to medial pterygoid, and last muscle to check is the lateral pterygoid. Some people say that you check from the lateral pterygoid. I suggest that the better is to start from the masseter, go to temporalis, then go to medial pterygoid, and lastly you check the lateral pterygoid. That is the sequence is more advisable.
Nice. Thank you so much, Dr. Shah. I think question session is closed now. I
Thank
thank
you.
everyone of all of the participants also. Dr.
Thank you
Arshad,
very much. Thank you very much.
thank you so
Inshallah,
much.
next time we are going to start the treatment planning and how we are going to treatment. Thank you. Thank you, everyone. And thank you to International Dentistry Council as well as International College of Dentists for organizing these webinars for the students and the undergraduates. Thank you very much.
Take care.
Assalamu alaikum wa rahmatullahi.
Wa alaikum salam.